I'm glad to be here to take us through optimizing neonatal care through triage, stabilization, and referral. I want you to pay key attention and make sure you go home with something. So by the time we are done with this, you'll be able to know how to triage babies when they come to your facility, and how to, the categorization and classification of triaging, and how to stabilize them when, they are giving birth to and when they are kind of ill, and how to refer to facilities that can manage them if where you met them, you're unable to. Okay. So by way of introduction, neonatal triage is actually a continuous process of rapid assessment and sorting out of sick newborn baby, their arrival at a referral hospital, to enable prioritization of care and treatment of patients according to their need and the resources available in your facility. So when a newborn comes in with the mother or caregiver, they are frail, and you think it's an emergency, you have to put a hold on administrative procedures and not let them be in the queue. So babies are quite frail, and you don't want to keep them waiting. In our facility, we really don't keep them waiting, and it's actually mostly the consultants that see them. So the key thing is that you don't want them queue, and you don't want them exposed to other children that are ill, so that they don't get infected because they are immunoplegic. And also, you kind of help allay the parents' anxieties. So, and this will also help us prevent delays of treatment if the child is critical, baby is critical, or optimize the limited care resources available. Okay, now we are going to talk about the classifications in triaging. You have the emergency, priority, and non-urgent. Emergency is kind of very critical. You don't keep them. So you just, immediately treat. You take quick action. So in emergency condition is where you initiate emergency treatment immediately, and you have your complete assessment. So this is done in minutes. You just start treating. You don't wait. So a child comes in convulsing. You just take up the child, abort the seizure, right? Then priority sign. Well, you ensure you assess and treat without delay too, but you could actually, maybe possibly be in a queue, but not so long, and then assess rapidly and act quickly, because a child that comes with priority sign can tip into emergency sign, which you don't want to happen under your nose. So this time, the time taken for assessment is 15 to 30 minutes. Then the non-urgent signs, they are really not emergency and they are not priority. So you actually, what you do here is to provide health education, counsel parents, allay fears, make sure they are well, communicated to, and it actually has a flexible timing. So what are the emergency signs? Well, if you see a child grunty, a child breathing so fast, more than normal, a child convulsing, a child with low pulse rate or low heart rate, a child that has cold extremities, it's a no-no. You don't let babies, get cold. So, and then a baby in shock, an unconscious baby, or a seasoned baby, or a baby that turns blue. Maybe they just came into your facility and the baby is already blue. It is emergency, and the treatment commences before, even administrative, purposes or procedures come in. Then the priority sign here, child might come in hypothermic, but not as low as what you have in emergency sign. So the temperature is between 36 to 36.4. That's the early hypothermic signs. And then respiratory distress at less than, more than 60, but less than 70. Don't worry, you all will get the slides. So, and then a child is irritable, excessive crying. You know, there is jaundice that has extended from the face and upwards. So they are, you know, categorized under the priority sign: severe pallor, congenital malformations, and extreme weight beats, birth weight, more than 4 kg and less than 1.5. So those are the priority signs. Then the non-urgent sign here, there are things we'll see, and you know, parents are just concerned and kind of freaking out, but they are actually not so bad. They are just normal physiology. Examples: baby just passed greenish poop, and now you said, oh, the poop has turned yellow. Oh, doctor, is this okay? Is this okay? Baby has started eating. So that meconium should go. And then the normals too should pop up. The normals two colors should form. And then maybe a baby pause setting. Once in a while, they feed, bob, and, you know, sometimes they regurgitate their feet. Yeah, it's okay. So you cancel the parents. Maybe minor birth trauma, conjunctival hemorrhage, caput succedaneum. I did not say subglear hemorrhage because that one is actually an emergency. Can make them anemic, severely anemic, and you know, jaundiced, severely jaundiced. So in non-urgent sign, you have the mild jaundice that is just only on the face, and some minor malformations like talipes, not congenital heart lesions, and then maybe skin infections, umbilical infections. So now, in the emergency management, you have the ABC of resuscitation. I am not going to dwell on this now because our facilitator is going to give us the meat of ABC of resuscitation in our next engagement. So we know all this, right? So always follow the ABC sequence. Don't move from the next step to the other until the current one is actually secured. So if airway is patent, a baby can breathe, then you move to breathing. You don't move from airway to circulation. No. It is a stepwise engagement. So here is the emergency treatment protocols. Hypothermia, how do we manage it? Make sure the baby is warm after delivery, and you put the baby under radiant warmer, clean up, remove the napkins or anything that is wet around the baby, because that can tip the baby into, you know, being hyperthermic. So you make sure you monitor the temperature regularly. And please, as we are, you know, managing and maybe in a facility where there is no radiant warmer, you now say get hot water bottle, or you put some people could use what's it called, sachet water, and kind of warm it up, and I'll say put it around the baby. Please, hot water bottle is a no-no because of the risk of burns. You don't want to hurt your babies, right? Yeah. So, and then apnea, a gasping baby, you need to, you know, position the head very well, make sure the airways patent, suction the mouth first, then the nose, and clear. Then if the child is still apneic and gasping, you can start ventilating and all, but I'm not going to dwell there because we are going to talk about it. Then severe respiratory distress, still the ABC. I don't want to oversize on that. Then when you're done, you can commence the baby on direct oxygen or CPAP if it's a preterm baby, and or maybe a term baby that is quite ill and needs respiratory support. You don't want them to get exhausted when they are breathing, because respiratory distress could give exertions. You can commence on intranasal oxygen and make sure you monitor them closely. Emergency treatment for bleeding. You have the hemorrhagic bleed or hemorrhagic shock and the non-hemorrhagic shock. So this is how we manage fluid resuscitation. Remember, they are babies and they are not older children. So you you give normal saline or Ringer's lactate at 10 ml per kg over 10 minutes, and monitor and monitor closely. It's not 20 to 30 ml per kg. Hello, good job. So then those that are actively bleeding, you can give blood transfusion, ensure the bloods are well matched, and also commence intranasal oxygen, because in hemorrhage, when they've bled and are anemic, the oxygen circulation is kind of depleted. So you need to support with oxygen even before the blood comes, before transfusion. Then if it's not hemorrhagic shock, this is how you manage. Then if the bleeding is from, you're suspecting vitamin K deficiency, you will give vitamin K1. Then if the anemia is so much, you can also transfuse. Then in a comatose baby, this ABC of resuscitation, check the blood glucose, abort seizure with phenobarbital. You could give 10 to 20 milligram per kg as the loading dose, and then monitor the babies. So the assessment for priority signs, remember I talked about the weight, less than 1.5 and greater than 4 in, I think in the non-urgent, and then priority assessment is actually based on weight classification, where in less than 1 kg baby, the extremely low birth weights, you make sure you keep them warm. Please, that's aminophylline. What we use now is caffeine citrate. Hello. So you ensure that their glucose is checked, PCV checked, you keep them warm and monitor temperature 30 minutes, then hourly, and be sure that the small babies are well, they have good thermoneutral environment. And I would say monitor and manage them in an incubator, because it gives, not under radiant warmer, it gives a better and prevents, heat release from convention and all that. So this is the way we manage our babies based on their weights. KMC comes in at the weight of 2 to 2.5 kg. And then commence feeding and ensure that the babies are all well. So communication during critical care. Communication is key. Very, very important. You could see husband and wife having issues because of poor communication. So even in the hospitals, there could be issues with communications if information is not well passed, or the doctor or caregiver, hospital personnel is not well informed or doesn't know how to, carry this information to the parents. So sometimes you see parents coming in worried, frightened, or upset. The baby came early, upset. A wife had cesarean section and the father is, not happy. Financial implications, involved in care of the child. So these things are things that come up. What do we do? Always ensure that you see your patient in a private, secluded, comfortable room where they are well seated before you could come to their level to, talk to them. Also, you always respect privacy and confidentiality in all communication. Do not use jargons or ambiguous words when you're trying to pass information across to them. Ensure that your words are clear, explicit, and simple. Then encourage them to ask questions anytime, even in the course of the communication. It must not necessarily be at the end when you're done talking. You can ask or then pause and ask them if they have any question. Then you also, you go ahead with what you're, telling them, or the information you're rendering. Then make sure you use appropriate language. Communicate in the language the parents understand. So if it's maybe someone that cannot speak English, you can get someone to help you interpret, so that there will be a seamless communication and good information passed across. Okay. I would move into stabilization and referral or transporting of babies from one facility to another. So transportation of a sick or preterm babies to a center with expertise and facilities for the provision of advanced and specialized care can be shown to improve outcomes of the babies. So my colleague, Dr. Taiwo, talked about, transporting babies in utero, that here it is actually the safest and the preferred mode of transportation for, babies. But in a situation where there is an emergency, mother needs to be saved, baby needs to come out, baby needs to be saved, we have to deliver and then move the babies to where there is experts, they can get expert care. So I will actually run through that. The benefits for specialized movements of babies is just to have access to advanced neonatal care and have access to specialized equipment and specialized health care workers who will manage them appropriately and for improved survival rate in babies. So there are types of transfer. You have the inter-facility and intra-facility transfer. So intra-facility transfer is transfer within the same facility, maybe in a teaching hospital where you want to move the baby from NICU, or maybe you want to move the baby from the theater to the special baby care unit, or maybe the baby had surgical intervention and you want to move the baby to a recovery room or back to the NICU from the theater. So movement of baby within the same facility between departments or units is the intra-facility transfer. And the reasons where we have that is maybe diagnostic procedures, surgeries, and all. But the inter-facility transfer, which I'm going to dwell more on, is movement of baby between different health facilities, which could be from healthcare, health center to a secondary, center, or secondary to tertiary, or private to public, or public to private. It's, could go either way. And reason is also for specialized and advanced care. So these are the 7 steps of inter-facility transfer. Decision to transfer, which must be made by the most senior doctor or a managing consultant. Communication, pre-transport stabilization, documentation, transporting the baby, that's the process of transporting, managing deterioration when the baby is on the move, and the arrival and handover. So communication, very important. If a baby needs to be moved from one facility to the other, first of all, the condition should be clearly stated to the parent. Please, this child has this and this. We are unable to handle it here. We are going to refer to a tertiary center where they have, multidisciplinary approach to manage. So you explain the current condition clearly and honestly. You're telling them the truth. So you tell them the reason why you're transferring and what care is needed that is not accessible at the moment where you are, and reason why you're going to take to another facility. And then the specific facility and location of the hospital you're taking the baby to should be known and also communicated to the parent. Also, you make sure that documentation, very important and very key, that you document all that you have done or communicated, and also ensure you get documented informed consent from the parent. Make sure they understood what you're saying or what you have communicated to them. Then you also reach out to the hospital you're referring the baby to make sure that there is space to accommodate the baby and they can manage the patient or the guest you're sending to them. And how do you do that? You put a call through. You could talk to a consultant, or talk to the nurses. Or there's one thing from where I did my residency, where you have compound office. the nurses that at the compound office, you speak to them, and then they will ensure that the NICU, they have space, and they start pre-warming incubator and start getting ready, waiting for the baby to come. So there should be a direct communication which aims to speak directly with the receiving health worker, and then also continuous communication. Even on transit, there is communication. Maybe we are in the next 20 minutes, we'll be there, and this is what's happening to the baby at the moment. You do that, and then also have everything documented. So step 2 is the pre-transport stabilization, where you ensure that temperature is stable. There is normal thermoneutral environment for the baby. It could be, well, you can't carry radiant warmer. I don't know if I've seen any mobile radiant warmer before, but ensure that baby is kept warm or is in the incubator, or KMC is done either by the mother or the father during transportation. Although they preferred, if not in utero, the preferred means of transportation is in an incubator for, very sick child or preterm babies that cannot maintain their temperature. Then ensure that they are breathing, and their breathing is actually normal. But if you have any challenge during the means point of transportation, the first aid boxes and other equipment in the ambulance that we could use to ensure that breathing is stable, there is adequate perfusion, IV access patent and all, then the baby is normoglycemic. Even en route, you could also check, depending on the distance, check the glucose level of the baby, and make sure you give antibiotics to cover for, sepsis. Then we have the special pre-transport considerations, aside from ensuring airway, thermoneutral environment, and circulation and all. These are for babies with congenital abnormalities. Thank you so much. Congenital abnormalities. So these are the way you ensure they are, safe and kept all put together. Step 4, documentation, very important. So in the referring letter, or even in the case note of the baby, you should have the reason for presentation, that's the presenting complaint, examination findings, especially the positive examination findings, working diagnoses, interventions done, investigations done in your hospital before sending out, and then reason for referral. Why are you transferring, and is it necessary? And then investigation. I've said that you could print out the notes, the investigation report, and attach it to the referral letter and the documentations that you have. If the baby was sampled before sending out, you could also send a sample, but samples of the baby to the referring hospital. So the next step is step 5, transporting the baby. Preferred, if the baby is already out and you're sending from a hospital to another, the preferred route or means is ambulance with full resuscitation capabilities. That's the preferred and the choicest. And then where it's unavailable, maybe in primary health care and all that, you could, use the private cars, and where there is no ambulance service. And then other, maybe those living in riverine area, water transport areas and all. And then in the highbrow area, helicopter ambulance could be used. So, and in moving these babies, there must be a health personnel accompanying the baby from one facility to the other. So the escort level must match the baby's clinical condition and the risk of deterioration. So if it's just routine care that the baby is going for in the the hospital that we were referred to, no medical escort is needed. But if there is risk of deterioration, a trained medical personnel will assist. Then if there are intervention and there's need for detailed observation and intervention, a nurse and or a doctor goes with the baby. But when there is multi-organ support, 2 trained medical personnel should go with the baby in the ambulance. So care during transport, A, B, C, D, E, F of resuscitation. So this is because my time is actually running off. So do not try to resuscitate the baby in a moving vehicle. Please, the vehicle should stop. And then if there is any facility or health facility that is close to you while en route to the tertiary facility where you're referring the baby to, you could, drive in there and make sure baby is stabilized, then you continue the trip. Step 6 is managing deterioration en route. Appropriate personnel with appropriate skills and then appropriate equipment should be in the ambulance. Okay, like there you have the mobile incubator in the ambulance, and then you have the emergency drugs in the ambulance which you could use and help with resuscitation. But the safety first is actually the key. When in doubt, stop and stabilize. A delayed arrival is better than a dead baby. True or false? True or false? I want to know those that are sleeping and those awake. Okay. So once you get to the hospital where the baby is supposed to get the expert care, there should be a handover from the personnel that escorted the baby to the tertiary facility. So there could be, either a verbal account, although remember you've already documented and you have your paper. Make sure that the patient history, vital signs, treatment, and clinical events during transport is handed over to the new health personnel taking over from you. And then the referral forms and all relevant documents, investigation reports are all attached and handed over to them, and ensure that the medical and nursing staff assuming responsibility or receiving the receiving staff has information, good information about the baby, because timing is of essence. We don't want a back and forth communications. So like us in our hospital, we have our handover checklist. Once they come, you just checklist combine from the referring to the referred and ensure that everybody's on the same page so that we buy time and not, waste time in managing the babies. So intra-facility transfer is just the same as what I just discussed, but it is within the same facility. Equipment required when you're going from maybe radiology to maybe from the NICU to radiology, ensure you have your ambu bag. You could carry the baby with oxygen if the baby is oxygen dependent. But ideally, those radiology machines should come to the baby, not the baby going to them, where things work actually. And then ensure the resuscitation bag device are with you, then you're monitoring continuously. Then this is the equipment for transport, which is very, very vital. I will not talk about it. Then family-centered care during transport. Make sure you're carrying the parents along. If anything changes, you let them know. Even if the baby is stable, still talk to them because communication is very vital. In conclusion, safe transport is very important. So safe and effective neonatal transport is critical for improving outcomes for sick and preterm newborn babies. Every step matters. And then ensure that there is standardized protocols of triaging, clear communication, stabilization and transporting, appropriate documentation and careful monitoring are done, because these things are essential. Very, very essential. Then careful planning cannot be overemphasized. Thank you so much for listening.